Hello, everyone, and welcome back to another episode of the Concussion Nerds podcast. And this week, I get to introduce you to a very special guest. Dr. B is, because I can't pronounce his last name and he's going to say it so much better for us in a second, is a board certified chiropractor who specializes in upper cervical ligament damage, permanent damage, particularly whiplash. And he's going to explain what he does so much better in a moment. But I wanted to have him join us because we know here that concussion is multifaceted and we have our different phenotypes. And we know that an element of that always involves the neck. And so, being a whiplash expert and an upper cervical focused clinician, who better to have than to help give us more information on this area? So, Dr. B, welcome to the podcast.
Thanks for having me, Natasha.
Could you do me a favor really quick because my intro was so below par? Can you give us some more information about who you are, what you do, and why you love what you do?
Sure, absolutely. So, like you said, my name is Dr. Sasha Blaskovich. Dr. B is what people refer to me as usually. I'm a board certified chiropractor, and I have developed a clinical focus on the upper cervical spine, but more precisely on an unstable upper cervical spine as opposed to just a positional component of the upper cervical spine. So, a dynamic version of what a lot of other chiropractors do as far as trying to manipulate and correct malpositions. I focus on why something would be constantly or almost constantly out of position. And that generally relates back to permanent ligament damage from a whiplash/ concussive type trauma that involves acceleration, deceleration, where the premise is that these connective tissues, these fibrous connective tissues like ligaments and cartilage would get permanently deformed or damaged or torn, whereby the remainder of what's left does not support proper integrity of the spine and most importantly, proper integrity of the atlas and axis relationship. So the top two vertebrae in the neck, and then how them having excessive movement correlates to brainstem irritation on a regular basis. And then the brainstem irritation is then trickling back up into the skull. And then we call it concussion. But oftentimes all the imaging in the world that's done on the brain doesn't really solidify a proper diagnosis because there's no findings. Generally, it's unremarkable. And so determining that somebody has upper cervical ligament damage and permanent instability can explain a whole lot of the symptoms that people are having, whereby, the simple diagnosis of concussion doesn't cut it.
Okay. So I'm going to jump into my physio school brain here because we have clinicians and we have individuals on concussion journeys that definitely tune into this podcast. And we have all ranges of levels of knowledge and education that listen here too. So when I was in physio school, cervical instability meant spinal cord damage and you were going to end up in a wheelchair. But I feel like, and I know from my own clients, there's degrees to that. So can you, because what I don't want to happen is people hear cervical spine instability and we start to ignite fear. So
Mhm.
can you explain what that means and the kind of the spectrum of that a little bit more to the listeners?
Sure, of course. So there are different grades of ligament laxity. So you have your grade one, two, three, four, and four being, diagnosed as a full rupture or complete, irreversible damage to a tissue. When instability has generally been talked about with relation to the cervical spine, you're right. It generally focuses on everything below C2 where the discs are. And if a fracture happens above that, that's very notable because they can see the fracture. And so there's something that, the medical community sees that can be done to things that are fractured or no longer connected as far as bony tissue. But when you're looking at some of these soft tissues, such as ligaments, it's not readily evident generally at the start that that has occurred. It's usually because the symptoms continue to persist, whereby therapies don't stick, treatment protocols don't really run as they normally would with, your average person that comes with a suspected neck. And so, yes, when you have, mid to lower neck instability, it can irritate the spinal cord. And then again, that would cause stuff downstream. But when you're talking about stuff upstream, back into the head, it's not common that stuff below C2 would trickle up there. It is possible, but it's generally at the level of C1, C2, and then the skull and C1, which would be termed C0, C1. When you have instability there, that tends to kink the brainstem region where drainage of the CSF from the brain, which is made in the brain, needs to occur at the same rate as it's being produced. And so if you have kinking of that ever so slightly, you're producing more than you're draining. And so by default, it trickles back up in and it actually starts to accumulate inside the brain. whereby you get distending of the ventricles or the cisterns where the CSF is made, and then that compresses the brain, and you then experience headaches and brain related symptoms, which would be deemed concussive. And it's not necessarily the brain itself that is the main factor of that symptomatology. It could very well be the brainstem being kinked by an unstable C1 or C2, causing less drainage to happen, thereby backing up into the brain. And then when you get the distension, the skull is a fixed entity, so it can't expand at the same rate as fluid accumulation can, and so it starts to compress brain tissue. And there you have then the symptoms that could be diagnosed akin to the concussive like pattern. And
Right.
so instability is, I think, probably one of the most overlooked things in medical care, or let's call it manual medicine, where we're dealing with spine and joints.
Mhm.
Most of the focus is on restrictions in movement. Unfortunately, there's a lot of people out there, especially the ones that don't respond to the therapy the normal way that they would expect to be responding to it, is that their actual underlying problem is not restricted motion in the joints. It's actually excessive movement in the joints, which then causes the muscles to get rigid and start to compensate for that and guard. And
Mhm.
so the expression is a lack of range of motion, but it's not a true lack of range of motion in the joints. It's a lack of range of motion because the muscles have overreacted, and properly so, to an actually overmobile joint system.
So the therapist that I train in my concussion nerds program and like myself and my own team at Symphony, so we kind of pride ourselves on doing this multi-systems assessment of which obviously part of it is a cervical component. But for you and for us, like what would be some of those flags that you could make clinicians aware of that we might need to be actually looking deeper into cervical spine instability? And if we suspect that, what do we do?
The most notable symptoms to look out for are dizziness, vertigo, balance and coordination issues, blurry vision, ringing in the ears, fullness in the ears, hoarseness of the voice, headaches, obviously, pressure in the head, especially suboccipital, just underneath the skull. And I think for therapists dealing, especially with the vestibular group of therapists, because these are considered vestibular like patterns of symptoms, that if the patient repeatedly gets flared up from vestibular therapies intended to improve upon their vestibular symptoms, then I would, especially because that involves change in head and neck position. So it's not just, semicircular canals and the fluid sloshing around in there that gets affected. You have mechanoreceptors, proprioceptors in all the joints. And so when that doesn't jive with what the eyes are telling the brain and what the inner ear is telling the brain, then you're going to have these vestibular like symptoms. And that's generally because the endpoint of these joints that have been, injured, where the ligaments have been permanently stretched or torn, comes at a later endpoint. And so then the inner ear and the eyes have told the brain, this is what has happened as far as motion. And then because there's a lag between that and when the proprioceptors from these damaged joints tell the brain what's happened, you get this disconnect. Not to mention that if you have an unstable upper cervical spine, the actual atlas itself might be eliciting enough pressure on the medulla to actually affect the vagus and the glossopharyngeal and the spinal accessory nerve. And there's even people that talk about, hypoglossal, so tongue related symptoms as well. And so when patients are discussing those things, they're actually very relevant to listen to, because that possibly could mean that their unstable C1 is irritating their brainstem at that level enough to actually elicit cranial nerve symptoms that aren't vestibular in nature, but they're actually compressive in nature.
Mhm. Well, and I mean, I've had a client. So I say for all my clients that come and travel and come work with us, we do that. Like I said, we do this multi systems assessment. And then if I don't see things in my assessment, because we do cervical spine, but then very much a neurology type treatment. If I don't see something that I concretely think that is explaining your symptomology, then we talk about I'm not the right person and we need to
Mhm.
find you the right person. And it's happened once, I think, in my career where we had someone come and he was coming for an intensive and we did the assessment and it didn't piece together. And then what we actually did is he went for a motion x-ray
Mhm.
and we discovered some instability in his cervical spine. And so for me, it was, you know what, you're having symptoms. And he was that person. I was like, he was having symptoms of dysautonomia because of the instability and the brainstem. And so for me, it was like, that needs to be the focus. And then if the cervical instability resolves or what's resolved around that, then if we're still having symptomology, we can come back to that. But the question is, so it was discovered with him with this motion, flexion, motion extension x ray. Can you explain what that is and how that's different from regular imaging and when someone should be advocating or reaching out to get an imaging like that?
Sure, absolutely. And just to tie back to your last question, probably 10 out of 10 of these patients eventually get referred to an ears, nose, and throat, so an ENT doctor.
Mhm.
And I would say 9 out of 10 of those come back with a clean report as far as there's nothing that was found by the ENT. So I think that's for clinicians, if they're treating somebody vestibularly, the person's been sent to an ENT and a thorough evaluation's been done and it comes back clean. That's when the spidey senses should start really tingling and thought of maybe a motion x-ray should reach the forebrain of the therapist. And so motion x-ray is more than just flexion and extension. It's dynamic, it's real-time video. And flexion extension, unfortunately, is the only component that gets assessed in mainstream medicine. So they will do a flexion and extension regular x-ray and it's a flexion position, still snapshot. They'll do a snapshot in neutral, and then they'll do an extension snapshot at the endpoint. However, they miss what happens from endpoint one to endpoint two. And having conducted thousands of motion x-rays myself, I can tell you that the point of most incriminating excess motion rarely happens at the endpoint because our neuromuscular system has an amazing capacity to recalibrate position
Mhm.
once we've reached our end goal. So it's during the actual motion from A to B that you often see the excess motion that would be pathologic. And then once you get to the endpoint, it recalibrates to make it look like it's not as bad. And so when you do a static regular x-ray in the flexion position, so you haven't watched them move into that position, you've just positioned them there, said, don't move, don't breathe, take a snapshot, and you do the same thing in extension, you can possibly be missing much more noticeable pathology between those endpoints. And then moreover, motion x-ray, we also focus on doing a rotational component because obviously our necks and our heads can rotate, plus they can tilt side to side. So there are three dimensions of assessment that should be done. And we do with motion x-ray, and we have been the entire time we've been doing it. Whereas medicine tends to focus on the flexion and extension component. And so if they don't notice anything in the flexion and extension, because they're mainly focusing on the ADI, which is
Mhm.
basically the front part of C1 separating from the dens of C2, assuming that only the transverse ligament is the possible perpetrator. But we've got several other important crucial ligaments that connect the skull to C1 and C1 to C2 that can't be assessed in flexion and extension. And so the three-dimensional approach tends to provide the most relevant information that is clinically, helpful both in therapy and also, prognosis and expectation. And I would probably say that the open mouth side to side bend, looking at C1, C2, is by far the most relevant as far as diagnosing upper cervical instability goes.
Crazy. I love it. So I know people travel to come work with you from all over. Like we talked about, you practice in Canada and the United States. So if someone has this, then what? Like, what does treatment look like? I'm sure you do more than just diagnose.
Yeah,
What does treatment look like after that?
sure. Sure. And I've actually posted a lot of this to, freely help any therapists or clinicians out there who are possibly dealing with this, and even patients who may not be able to get in for a treatment 5 times a week, because ultimately this type of therapy, when you have these problems, is actually 7 days a week is justified. And so
Okay.
to be able to learn how to do this to yourself. And so I've got, these videos in the short section of my YouTube channel. There are shorts on how to treat this yourself. And then one of them shows me squeezing my SCM. That's the tile for that video. And then there's about a 10-minute video that would be intended for clinicians giving an overview of the structures involved in the upper cervical spine that would be most commonly needing treatment, because it generally is a rotational instability at C1, C2, because the number one job of C1 and C2 is to rotate. And so when you damage the ligaments there, you already have the most mobile component of our spine becoming even more mobile. And so it's a rotational instability. So you want to be addressing the rotational muscles that would support rotation, or that
So
would be
we'll
on.
what we'll do, Sasha, I'm just gonna interrupt really quick 'cause for those listening, is we will drop the links to both those videos in the show notes, both that short one and the longer one. So I'll get you to send those to me after. So that way
Sure.
we can just drive people right there so they don't have to go searching for it. We'll make it easy
Abso-
for them.
Absolutely. Yeah, absolutely. But the premise is that because you have permanent ligament damage, and so if I could define permanent ligament damage, that means that it's actually not going to heal. What could be considered healing that happens in a damaged ligament is generally, so if this is the normal integrity of a ligament and you've got it partially torn, so now it's lengthened a certain factor, it does not recoil back to the resting length and then heal or scar. So what happens when you have that stretch or that deformation of the ligament, it's going to scar up and heal in this length position. And so now,
Right.
no matter how you slice it, those bones will move that excess amount from that moment on. And because our muscles have sensors built into them, and there's also another YouTube video there where I explain this to a massage school, the sort of neuromuscular component and how that eventually involves the central nervous system, which then leads to an elevated tone of those muscles, which causes these patients to repeatedly come back to us with the exact same muscles being overly toned or tight.
Hmm.
But the notion is that these muscles respond to that instability in an involuntary way. So they sense themselves stretching, they contract by default. That's their natural response. And as they repeatedly do that, then signals start to trickle up into the central nervous system. Central nervous system gets involved and actually sends a tone change down to that muscle so that it doesn't have to undergo that stretch as much because it's already pre-shortened. And so because of that phenomenon, then people's muscles get tighter and tighter and tighter to compensate for that instability. And at some point in time, that tightness relates to what then chiropractors term as a malposition or as a subluxation. And so then you can address the subluxation as an isolated entity, or you can assume based off the patient's symptoms that they might have actual instability. And so the tightness is not truly coming from the joints, it's coming from these muscles that have become more rigid as a means of protecting themselves. And so the technique that I implement is basically NIMO, receptor tonus technique, which basically translates into acupressure. And so
Okay.
that's basically finding the trigger point in these muscles and pressing and holding. And I've sort of taken that concept of Dr. Nimmo and I've made it my own, if you will,
Hmm.
because their premise is holding a muscular tissue from 7 to 10 seconds and a ligamentous tissue from 3 to 5 seconds. Where I tend to hold the trigger points for a minimum of 20 seconds and sometimes even well over a minute. And by doing that, the depletion of the lactic acid and the forcing of the cross bridges to release actually puts that muscle back into a responsive and functional state so that it can again undergo the stretch, contract, eventually evolve the central nervous system and eventually change the tone, thereby needing treatment again. And that's why it's so relevant for patients to be able to be empowered to self treat should they be willing to try and should it be successful for them, because it is an actual thing that they would need to do daily and sometimes multiple times a day to hit that reset button so that they can function within a somewhat more acceptable norm. So they're not always depending on a treater to do it passively.
Yeah. So to clarify, so we're working on this combination of
Yep.
resetting the tone with the acupressure, but then also when the tone resets, taking ourselves through that range of movement. And then are we doing strength? Are you leading to strengthening of the other musculature around to support as well?
That can be done. That happens naturally as a domino effect. But in reality, because that muscle is constantly undergoing a stretch contract, it actually is working out just by existing. And so, and this is oftentimes where I think that the strengthening and stretching concepts of therapy fail or don't have the results that are hoped and expected, is because these muscles have taken on a level of rigidity. So they're not apt to stretching them out. You can't elongate them from attachment to attachment and expect them to not be injured.
Yeah.
And you can't strengthen them because they're already pre-contracted and in a rigid state. So their contractility is minimal. And so
Yeah.
when you release the trigger points, yes, theoretically, you can then throw therapy to that region at somebody for strengthening. Stretching, I'm not sure that I'm a fan of at all. And we
Neither.
can get into that, but strengthening, I would be a fan of that. And I actually am a fan of that. And we're currently testing out a device that I designed that has just literally gone on the market recently. It's called Dr. B's Neck Stabilizer.
Hmm.
So it's an aluminum metal contraption that basically hangs on your wall and it can fold out of your wall and then you can fold away so it's out of your way. And it's got a head strap tethered to 4 elastic bands that you can, from the starting point, you can go in any direction. So you can do rotation, flexion, lateral flexion, combinations of movements to basically hit the fast fire, because you want to hit the fast fire, fast twitch component of this, because
Hmm.
these muscles should be intended to be quickly responsive so that as an unstable segment is starting to go off center, that they quickly pull it back. And
Mm.
so the device is not intended to train strength. It's intended to actually improve the response time of these muscles to the stimulus. And so, for example, when you're playing a contact sport such as football, you've got these, scrawny receivers that are being bounced around and tossed around by big linebackers, but yet they generally get up and run back to the huddle and they can play the next play. And that's because they're so much more endowed with fast twitch fibers that their muscles response time to noxious stimuli, so traumatic hits, is so much faster that they actually protect their ligaments. And so this device is intended to train the rapidity of that
Mhm.
neuromuscular connection, because we're hardwired at about 3/10 of a second. So when a stimulus occurs, our muscles are intended to respond within 3/10 of a second. That's kind of the average human being. But the peak acceleration of a trauma, so whether it's a football player hitting you or a linebacker hitting you, or whether you're getting rear-ended in traffic, that peak acceleration happens in 1/10 of a second. And so you're 2/10 of a second too late to have your muscles respond that are only capable of doing at 3/10 of a second. So the goal of this device, and we're in sort of the beta phase of testing it out right now, is to try to bring someone from 3/10 of a second response time, especially if they've already been injured and these muscles
Mhm.
need to have it, down somewhere near closer to 1/10 of a second response time, so that should they get in a subsequent injury, or are they a contact sport, elite contact sport person, that their neck is not only strong, but that their neck actually can respond at 1/10 of a second. So when they get blindsided, they're not going to injure their ligaments. They're going to have a muscle strain, which we know will heal unless it's fully
Mhm.
ruptured, in which case, the chances are less, but the chance of that happening is minimal because you'll then put the ligaments to the test before you fully rupture a muscle. And so the intent is to bring that closer down to 1/10 of a second response time, so that somebody who already is damaged has a faster response time for the future, so that they don't get into as many, flare ups. And someone who is uninjured at the moment, that they can prevent that and protect themselves from that should an event happen where they're not expecting it.
I love that. I'm now very curious about your device. So I'll have to chat more after that. And I just want to say, like, I do love what you just said, but like, please don't stretch like a tight, rigid muscle. Like it doesn't work. And
Mhm.
I always talk about with clients too. It's like you need to make something, and I think saying it in different terminology, but we need to make something more dynamic and having the ability to contract and relax before you can
Yep.
then train it, which is kind of what you shared too. So I love this.
Basically, so when you have a muscle fiber, there's a fixed amount of sarcomeres. And where the alpha motor comes into the muscle, it's not all the muscle fibers that get direct innervation from the neuron. So it's only a certain number, and then the rest get their gradient by diffusion. And so generally the trigger points are pretty much predictable, where somebody's going to get a massive amount of electrical impulse into a muscle. You're going to develop the trigger points. And so you're going to have those sarcomeres are going to shorten, become dysfunctional. And the sarcomeres on either side of that trigger point are going to elongate, also dysfunctional. And so by releasing the trigger point by just sustained pressure, you're going to release those sarcomeres, and you are in effect going to stretch that muscle tissue without stretching it. So you're going to
Mhm.
elongate the trigger point. By default, if you hit enough trigger points, you will elongate the entire muscle without having taken one endpoint and the other endpoint and pull them apart. So you do get
Right.
stretch, but not by the general definition of stretch.
What people think of when they think of stretching.
Yeah.
I love. Oh, I feel like we could talk forever. I feel like you have so much information to share and to help people with. And so, again, I think big picture summary is this acknowledgement. And we've talked about this too. And I've read studies and I've shared studies too that cervical spine injury, true cervical spine injury, and whiplash injury can absolutely mimic every symptom of concussion.
Absolutely.
And we need to remember that, right? And so, as clinicians, if we're doing our assessments and we are not finding, the vestibular findings, if we're not finding the visual findings, if we're not finding the nervous system findings, like if we're not finding these things, but our clients are absolutely still sharing symptomology of
Yep.
what we would consider concussion, that we need to make sure we're doing due diligence to be assessing screening for that upper cervical spine or referring to someone who can then help give us that deeper insight
Yep.
into what we need to do for cervical spine. And we can't, I think sometimes I always say to clients too, what I see happen a lot, Sasha, and you probably see this a ton too, is when we're taking history, because like you, clients, I'm practitioner number 20, right? Like for the
Yep.
clients that travel to come work with us, they're traveling to come work with us because they've exhausted what's in their area. And so we're rarely the first stop,
Hmm.
right? And then when we start to hear, so we always ask, what have you done? And we'll bring up the neck. That comes up every time. And I'd say the resounding statement that I hear a lot is, "Oh, I've had rehab on my neck and it is what it is." And it's like, but what have you done?
Hmm.
And very commonly, well, I saw massage therapy, right? And I always say, like, it's not that you didn't do anything for the neck, but you didn't take it all the way. You went halfway or you went a quarter of the way through the marathon of what a neck of fully exploring the neck is. And we need to make sure we're doing due diligence to explore the full picture
Yep.
of what the cervical spine entails.
Yep.
And so again, so you see clients. So if people want to get in touch with you, Sasha, if people want to work with you, if they are curious about dynamic x-rays, how does that work? What is the best way to reach you?
The best way is either just to call the office in either Langley or in Washington, and those numbers are both on the website, whiplashclinic.com. Another way that people, for example, somebody from Morocco contacted me yesterday wanting me to assess all of his MRIs and CT scans to provide some insight. as to why, in his case, 20 specialists have missed diagnosing him. And he believes, after, Googling and researching, that he has atlantoaxial instability based off of his symptoms and his past trauma. And so he wants me to assess. So people can reach out to me directly through the drblaskovich.com, so drblaskovich.com website. And that's specifically, I've dedicated that one for, as much as possible, helping people who aren't local and either don't have the ability to travel because of the severity of their symptoms and just need some expertise guidance as to, maybe finding some nuggets within their imaging and in their story that they could then take back to a local practitioner that might then take action with new information. So
Okay.
whiplashclinic.com or drblaskovich.com. And the other thing, I think that is crucial for people to understand, and therapists and clinicians, is that when people have a head MRI or a head CT, it generally omits the craniocervical junction. We're lucky that somebody, crop the area to scan a little bit bigger when we do see that area on a head or brain CT or MRI. And when they do the cervical spine X-ray or CT scan, they inevitably also skip the craniocervical junction on the axial slicing, and the coronals they almost never do. So even when a person gets an MRI, they think that they've had the gold standard of diagnostic imaging, but the single plane, so the sagittal plane, which is the side view, they will do from literally mid skull down to the, T4. So you'll get everything and then some. But then the axials, they start at the bottom of C2 and go down because there's no discs above that. And they're trying to evaluate for discs. And so these protocols have to eventually change to actually incorporate the craniocervical junction. So whenever I'm talking to a doctor or a neurologist or even a patient who's going to one of those physicians and they're going to be getting a cervical spine MRI referral, I inevitably ask them to demand that they get a cervical spine MRI, so the routine one, but to make sure that all three planes are conducted, so sagittal, axial, and coronal planes, and that all three planes include the craniocervical junction so that we can thoroughly assess C1 and C2 and not have to infer. Again, so just the side view is not enough to see that. You have to look at it in all three planes because there's relevant information in all three planes. And so I found that we're getting much more relevant information in doing that because now we're assessing it from all three sides. Should the doctors be willing to basically accommodate that? And it's just a matter of writing in the requisition because when they write down, routine cervical spine MRI, they're not going to get the craniocervical junction.
Okay. Well, that's insight for me too. Thank you for that. I'm definitely not the person to read imaging results, but
Yeah, so, like, I do that all the time, and that's, I mean, I'm not a radiologist, but I've had so much, outside continuing training
mhm,
and just practice and doing it over the last 2.5 decades that can't say that I see everything, but I see a lot of stuff that I oftentimes have to point out to radiologists, but it's not that they can't see it, it's that they're not trained to look for it.
yeah,
And there's a
absolutely.
wonderful gentleman who unfortunately passed away, not this past summer, but the summer before, Dr. Francis Smith from Scotland, and he was by far the world's most renowned expert at reading MRIs as far as it relates to the craniocervical junction. And so I learned a lot from him as well. And so these things are oftentimes there to be seen. It's just a matter of looking for them.
Looking for them. I love that. Thank you. If you could leave kind of one summarizing statement that you would like our clinicians and our individuals on a journey to know about whiplash and upper cervical and that piece, what might that be?
If the suspicion is there, refer for a motion x-ray because that
Mhm.
will definitively objectify instability should it be there. I mean, the second thing, and I think the most important thing for clinicians would be learn how to do the sharp purser test. Because if you have the suspicion that your patient, client, whatever you are going to call them, has upper cervical instability, and that generally means C1, C2, because the instability of C0, C1 does exist, but it's extremely rare.
Okay.
But if you have the suspicion that they have C1, C2 instability, learn how to do the sharp purser test and make sure that you do it on your patient when they're symptomatic. Like if they come in your office and
Mhm.
tell you that they're feeling dizzy and their vision's blurry and their ears are ringing and that they feel off balance, sit them up, do the sharp purser test and hold that for about 15 or 20 seconds, really mildly. And then see if they say, wow, my vision just cleared. My ears are no longer ringing. I feel more with it. And then what you do then is after holding that for about 20 seconds, you gently let it go and you ask them, what do you feel now? And if they within, 3 to 10 seconds say, whoa, all of my symptoms just flushed back, then you know that that's a pretty darn solid yellow to red flag that they are dealing with that and they should get diagnostically imaged.
That is like a beautiful, easy to put into action, like golden nugget for clinicians listening to this. Thank you.
Yeah.
It has
My
been an
pleasure.
absolute pleasure getting to chat with you. I'm not gonna lie, I'm gonna message you because I'm really curious about your device.
Sure. Absolutely.
And if I come to the mainland, I would love to come see your clinic too, because you're really only a ferry ride away.
That's right. Anytime.
Thank you so much for joining us. You've been a wealth of information. I feel like you have so much knowledge in your decades of experience that you could share with us. So we may have to have you back another time.
Sure.
Um,
Absolutely.
but have an amazing day to everyone listening. Please, all the links that Dr. B talked about are going to in the show notes for his website, his Instagram's there. We'll pop the YouTube videos he was talking about all in the show notes. So you can go click there and connect with him if you feel like this resonates for you. And until next week, my friends, we will see you then. That's today's episode. Thank you so much for tuning in. If you liked what you heard, give us a like, give us a share, give us a tag on Instagram, and please never hesitate to reach out. We love communicating and connecting with you. Until next week, my friends, have a marvelous day.